so last Monday. So in this particular procedure, we have a young lady in her late teens. She attended with bilateral occluding earwax. I'm just starting off here with her left ear. We're quite lateral, so we're near the entrance of the ear canal. You can see that the wax is really dark, really dry. There's loads of skin adhesions, and I am using a standard Zollner suction probe just to loosen the wax off the canal wall. I'm trying to obtain a suction grip and then making slow concentric circles, wriggling and teasing the wax, trying to lift it off the canal wall. It was quite stubborn and the skin adhesions were extremely tough, so I've now resorted to a St. Bart's ear hook, and I'm just trying to get in behind the wax and dead skin and gently lever this out. I'm just going back in there, and you can see the skin's more of the paler brown, and that's combined with the wax, which is a bit darker in shade than the skin. You'll see throughout the video this client's ear canal is extremely blocked, really impacted wax, and the wax spanned right from the entrance of the ear canal right up to the eardrum, and the average length of a human's ear canal is 3 centimeters, so I did have my work cut out here. And I'm just making slow but steady progress, and I'm just trying to insert the ear hook on the posterior concha canal wall. Again, trying to lift it off the canal wall, making it easier to remove the wax. And I've just loosened that segment there and gently extracted it. It is quite a long procedure, so I do apologise. Some of you may get bored throughout, but I think it's really important as a clinical ear care specialist to show you the whole entire procedure, because there's a lot more to it than meets the eye. A lot of people who are probably watching the videos just think, oh, why don't you just go in with a vacuum and suck it out? Why is he making a mountain out of a molehill? Earwaxes can be very, very challenging to remove. One of my co-directors of Clearwax is an ENT surgeon, and remember, he's a surgeon. He performs middle ear surgery, cochlear implant surgery, very intricate and complex surgery. And he himself admits that sometimes earwax can be just as challenging, more so because the client's awake, and the ear canal is very sensitive, very delicate, and obviously what's paramount when you're performing earwax removal is to take into consideration the client comfort levels. The last thing we want is to cause undue harm, trauma. So going back to the video, I've removed the outer part of the earwax, the lateral segment of the wax, using a St. Bart's ear hook. And when we go deep in the ear, like we are now, it's very difficult to use other instruments like an ear hook or Jobson horn, simply because of the fact you can't really get in behind the wax. And you may have heard me in my past videos, the inner 2/3 of the ear canal, it's literally skin on bone, whereas the outer third, the lateral third, it's skin covering cartilage, and the cartilage itself and fatty tissue is resting on the bone. When you've got exposed bone like that, if you make contact with the bone directly, it can be very uncomfortable for the client, and there's simply no way here, in this case, where I could slip inside or through the wax a ear hook or Jobson horn. Crocodile forceps just wouldn't be suitable for this. The wax here is a bit softer. By using forceps, you'd be gripping the wax and pulling away little segments of the wax. It wouldn't remove it in a large mass. So what I'm doing, just very patiently using the suction probe and making little wriggles around the edge of the wax, just to again loosen that from the canal wall. The wax here is lodged in an area of the ear canal called the isthmus, so that's about 5 millimeters away from the eardrum. And at this part of the ear canal, it narrows and then it protrudes back outwards. So in essence, you're trying to remove a large piece of wax through a narrow orifice, and again, it can be very challenging, more so because this part of the ear canal is very sensitive, as I alluded to earlier. You can see here I've managed to successfully loosen that large lump of wax, extract it through that narrowing, the isthmus, and it's more in the mid-canal near the entrance now. It's a little bit tough to remove. It's difficult to getting a suction grip, but it is slowly but surely removing. And you can see there the ear canal is now clear. There is a bit more wax there, but it's not occluding wax, and I've just gone back in with the standard size Zollner suction probe. The wax there is also adhered to skin, and if you've been watching a lot of my videos, or if you've been reading some of the comments, descriptions of my videos, skin can be very challenging to remove. The problem with skin is that it can clarinet when you suction it. What I mean by clarineting, the skin itself flaps very aggressively within the suction probe, and it emits a very high frequency whistle, squealing sound, which can almost be deafening, not only for me who's performing the procedure, but obviously the client, because that noise is occurring within the ear canal. Truth be told, that skin is not really going to cause much of an issue for the patient. It will naturally shed and migrate, but because I'm using a fine end gauge attached to the standard suction probe, the fine end itself is a lot quieter. It's also less powerful, so it's a bit more tricky at times. So obviously you can't hear the procedure sound here, but there wasn't much noise being emitted, so I felt as though it was fine for me to continue using that. But again, there's remnants of skin, and I decided just to leave that last bit of soft wax attached to the eardrum. I'm just delicately approaching that, so that's the posterior quadrant of the eardrum. Managed to remove a bit of it. Client found it slightly uncomfortable, so I just decided to leave that. It's again, her symptoms had resolved. Sometimes less is more, and I have to stress that. I know a lot of viewers hate seeing pieces of wax left behind in the ear canal or dead skin. As an experienced qualified clinical ear care specialist, when we train our delegates, we stress this so much. If you're trying to be too cute and trying to remove every single piece of wax, not only are you prolonging the procedure unnecessarily and therefore exposing the client to excessive noise levels and the chance of causing trauma, cutting the ear canal or causing bruising, bleeding, perforating the eardrum, it's not wise. You have to weigh out the benefits of removing the wax against possible complications, and it is designed to secrete wax and skin. So having a little bit of wax in your ears, having a little bit of dead skin in your ears, there's nothing abnormal about that. It's completely normal and healthy. So we completed the left ear. I've now gone over to the right ear. This particular ear, there's a lot more hair, and that hair is also matted alongside the wax, making it a bit more tricky to remove. It does sometimes also obscure the view, this hair. Not only the hair itself, but also the hair can be quite greasy. So when you insert in the endoscope, the grease on that hair, which we call cilia, can smear the tip of the endoscope. I often read a lot of comments, why don't you trim hairs? Why don't you kind of use a razor or a shaving device? There's absolutely no need for it. There really isn't, unless it's completely and utterly obscuring the view. Again, I'm referring back to what I said a few minutes ago. You only do what's necessary. There has been occasions where there's been so much hair in someone's ear that I quite literally couldn't see inside. So what I've done in that case is use crocodile forceps to pluck out this hair. Can be slightly painful, uncomfortable for the client. It's probably the same feeling as women who wax their legs or their eyebrows, but at the same time it is quite well tolerated. So I'm making some headway here, and again, just like the left ear, I'm just trying to get a suction grip and gently lift the wax off the canal wall. And we do that by making little wriggle motions, little concentric circles to loosen the wax from the skin adhesions that attach to the ear canal. Slowly but surely, the wax is loosening and I am removing it, and you can see again a bit of hair there. Although to the untrained eye, I might think, oh, well, you may not be able to see what I'm doing, but as an expert, I can, even despite that slightly blurry view and that hair, I still know what I'm doing. I can still I know the ear anatomy, I know it's safe for me to remove that wax. And again, we're quite lateral. Whenever you perform earwax removal, the risks increase the further you go into the ear canal, into the bony part where the eardrum is. Over here, we're just on the posterior lateral canal wall, so I mean the back part of the ear canal wall near the entrance. And you can see that skin here is presenting itself as the kind of the light grey, white, shiny substance. And you can actually see it peeling off the canal wall there. Similarly to the left ear, the wax is really dark in colour, very dry. This client is actually Asian, and in my experience, I found a lot of Asian clients, not all, but quite more so than Caucasian clients. The wax is typically a lot drier and with a lot more skin adhesion. So I would say it's either something to do with their diet or it's genetical. When I say diet, there's many wax consists of kind of 5 or 6 organic compounds. The majority of wax, believe it or not, is actually dead skin. You then also get sweat from the sebaceous glands. Wax is also made up of fatty unsaturated chains, cholesterol, and also alcohol chains. Combine that all together and you have earwax. So it may just be the percentage of earwax in Asian clients consists more of dead skin than the other organic compounds I just listed. So I've managed to remove the lateral part and I'm just now mid-canal. The wax is a bit softer here and you can see a few more skin adhesions. The problem with dead skin, if it's in the ear canal for too long, that skin can get damp, it can get infected, and it can also cause erosion of the canal, the bony part of the canal. So for those of you who suffer from excessive dead skin, I would definitely recommend you could use olive oil drops. Olive oil drops is a natural lubricant. Olive oil is also slightly acidic and earwax itself is slightly acidic, so it's a similar pH. And if you use olive oil as a rinsing agent as opposed to water, which we obviously advise against because water can cause infection in the ear, it can sometimes help with skin conditions. You may have noticed the video started to lag and I'm not sure why that is. I do apologise for that, so the video has slowed down. Hopefully it's not too much of an inconvenience for you. The eardrum there is fully visible. The client's symptoms have actually resolved, so it would be perfectly acceptable for any specialist at this point to stop the procedure. However, as I mentioned, skin, if there's excessive amounts of skin and it becomes infected, it can cause erosion of the bony part of the canal. So I've decided just to persevere a bit more, and I've actually instilled some sodium bicarbonate drops here. I find during the procedure sodium bicarb is actually quite effective with dead skin, but as I said earlier, if you're using it, if you want to use drops preventatively in your ears, then I would recommend olive oil. The reason for that is sodium bicarb, unlike olive oil, is water-based and it is also slightly alkaline in pH. So in some cases it can cause irritation, and with it being water-based, there's more risk of developing an infection. The risk is very low nonetheless, but I would recommend to use olive oil drops as opposed to sodium bicarb drops if you are doing so as a preventative measure. We're now on the anterior canal wall, and this is the bony part, and unbeknown at the time, that layer of skin that I just removed was actually hiding away a protrusion of the bone, and that's why we have to be so delicate there, because you'd be completely oblivious to that fact, and it's only until I gently lifted that dead skin I could see that bony protrusion. If I went in gung-ho, I would have made contact with that and been very uncomfortable for the client. Again, there's a bit of soft wax on the central posterior part of the eardrum. It wasn't actually causing the patient any symptoms, and in these times, especially COVID times, we are trying to minimise the time we spend with our clients. Audiologists can be quite high-risk professionals because we can't distance ourselves more than 6 feet or 2 meters from the client, and again, as you're probably aware from some of my past videos, some people do develop the gag reflex, and we're obviously trying to prevent people coughing in such close proximity to us during any procedure. We do wear full PPE, so we wear a surgical fluid repellent face mask, which we also provide to the client. We also wear a face visor, protection goggles, eye spectacles, disposable aprons, and also nitrile examination gloves. And you'll see here 3 still shots of all that wax I removed from the ear canal. It's probably one of the, in terms of quantity, some of the most amount of wax I removed from a patient's ear. So yeah, the client was extremely happy. I think it was a bit of a life-changing moment for her. She was